With that, we'll turn it over to Dr. Michael Stover, who has a vast experience of pelvic and acetabular fracture treatment at Northwestern in Chicago, and will present something that's becoming more and more of a common problem with our aging population, including myself in that group, unfortunately. So, Michael?
Okay, so we're going to present a case on a 72-year-old female, simple slip and fall onto her backside. A week prior to presenting to the ER, she complained of tailbone pain. She has some inflammatory conditions for which she takes quite a bit of prednisone each day, history of osteoporosis on some bisphosphonates. And on presentation, she had some sense of urgency to urinate, but was unable. On the initial evaluation, she had no saddle anesthesia. Her post-void residual less than 100, and she was discharged home with routine follow-up with her medicine physician. These are her x-rays from the emergency department. So if you look at these very closely, you'll see things a little bit more apparent later on. But they evaluated this, felt she had low back pain, and was discharged home with follow-up with her medicine physician. So a week later, she saw internal medicine. Now she's complaining of left groin pain, anterior thigh pain, difficulty walking, sitting, intermittent incontinence of bowel and bladder, felt like her left leg was giving out. So these are the x-rays that were obtained in the primary care office. They noticed now that she had a parasymphyseal fracture that you can see quite readily here on the left. They prescribed her a wheelchair along with her walker, gave her some narcotics, felt with her history of osteoporosis that they would have the endocrine physician evaluate her and send her to orthopedics for this fracture. In orthopedics, she was initially seen by a PA, and again now complaining of groin pain, now with pain radiating down the back of her legs to her knees. She was now incontinent of urine only, but she felt this is actually improving. She had a couple of episodes of bowel and bladder incontinence during the first 2 weeks, but she felt it was improving, and the PA ordered an MRI. So the MRI is here for evaluation. You can see that she has fluid signals within the sacral ala bilaterally. And so when you think of bilateral injuries to the sacrum, you should always think of a transverse component. So going to the sagittal section, you can see here at S2-3, she has a kyphotic deformity at S2-3 with surrounding hematoma, consistent with a U-shaped sacral fracture. So she was sent to my clinic. She's now unable to ambulate with a walker or max assist. She had severe pain with sitting, so she was mainly at bed rest. She still had incontinence, difficulty with bowel movements, and in my evaluation had decreased rectal tone in the clinic. Here's our radiographs in our clinic. So now just going back, you can also see from the initial film, she has fractures of bilateral sacrum. You can see that there's a slight cranial migration bilaterally. Not really a deformity seen on the mid portion and the parasymphyseal fracture. Here you can maybe get a sense of the sacral foramina at S2 are a little bit distorted, consistent with that transverse pattern. Here's your parasymphyseal fracture. And then with the lateral of the sacrum, now you can actually see the displacement. So here's the kyphotic deformity, translation of about 50% of the sacral body. We obtained a CT scan to better evaluate the sacral canal, especially with her neurologic complaints. So the bilateral sacral ala fractures. You can see here at the transitional zone, there's the S2 deformities you saw in the plain x-rays. Here's her kyphotic deformity, maybe a little callus formation now at 3 weeks, with complete obliteration of the sacral canal at S2-3. So this is an axial reformat in the sacral plane to show us exactly the sacral canal. So her diagnosis is a sacral insufficiency fracture. The morphology is U-shaped, and she also has sacral nerve root compression and dysfunction. So what are your treatment options? I think in this circumstance, it does seem appropriate that she should be stabilized and that she can then be mobilized better. She's lost her mobility status, and also what to do with the neurologic components of her complaint. So our plan was to perform lumbopelvic stabilization with no fusion. There would be no reduction really because there wasn't significant deformity, and we would do a sacral laminectomy as a form of decompression of the sacral nerve roots, and we'd explore these. And for me, I actually get a neurosurgeon involved with this portion of the procedure, so they can mobilize the nerve roots, and they also can help out if there's any durotomies or any traumatic injuries to the nerves. So this is our treatment that we prescribed, and this was performed along with the neurosurgeon. Due to our osteoporosis, we used augmentation within the lumbar bodies. Our fixation stems from L4-5, skipping the sacrum, and then using iliac bolts. We can use one iliac bolt. Initially, we used types of fixation here where these were fixed angle. These are actually polyaxial screws, and there can be some comments on that as well as part of the fixation, especially in higher energy injuries. Post-operatively, we prescribed protected weight bearing with a walker. We actually prescribed anabolic augmentation with teriparatide. This is an off-label use of a osteoporotic drug that can facilitate bone healing. These are her x-rays 6 months after surgery. She has a resolution of her neurologic symptoms. She has intermittent stress incontinence, control of her bowel and bladder for the most part. She has no pain except for occasional lower back pain, which I think is probably associated with the stabilization of lumbar spine without fusion. And she went on to do quite well. So here you can see CT scan proven healing or union of the sacral fracture, with our plans then to remove the implants that were canceled due to the COVID issues, and she still has her implants in place. So her diagnosis is a U-shaped insufficiency fracture. So with these fractures, your role of stabilization is probably in those patients that had inability to mobilize. Some fractures are actually inherently stable due to the compression that occurs with the fall, and they can be mobilized, but they just have to be followed very closely for any progressive displacement or neurologic dysfunction or inability to mobilize, and therefore you may have a role for stabilization in those patients as well. Early on, there can also be a role for the possibility of transsacral fixation that's been published before with Dr. Rout's paper. That doesn't necessarily apply yet to the osteoporotic population or how it performs in that population. The reduction is difficult in the setting of osteoporosis or really in any circumstances. Early on with the initial injury, with higher energy injuries, I use a table with hip hyperextension and stabilization of the pelvis to get a postural reduction. Direct reduction can be very difficult, especially in higher energy injuries, but is maybe indicated with wide displacements or spinal optosis. This is very difficult though, requires a laminectomy. You can use the pedicle screws above to the iliac bolts below for distraction. You have to then move the pelvis back up onto the sacrum while pushing the sacral body down. The construct, as mentioned, is typically L4-5 with iliac bolts. Usually one is fine if you just put this right above the greater sciatic notch so that there's a good buttress against the notch, or a stable buttress against the notch to limit flexion deformity and also rotational deformity through the screw. With fusion, I don't think there's any role for fusion at the lumbar segments, but you should consider fusion at L5-S1, especially if the lumbosacral facets are involved, as these can be a pain generator in the future. And there's really minimal loss of motion at the L5-S1 junction for most people. And then plan for removal of implants at 6 to 9 months following stabilization. So that's a case of insufficiency sacral fractures, not a high energy, but we see it more often. I think the point would be, if you have a patient, low energy injury, lower back pain, really look at their initial x-rays for sacral injury. If it's not apparent on the plain radiographs, MRI has been utilized a lot in our institution to diagnose the insufficiency fractures, the posterior pelvic ring. If you see bilateral injuries, always be really hypervigilant to look for a transverse component. And as you mobilize these patients, be careful as to monitoring for any further displacement, inability to mobilize, or sacral nerve root dysfunction. Thank you very much.
Thank you, Mike. That's a fascinating case. So you can go ahead and stop sharing your screen, and we'll let Dr. Rout start getting his screen up ready for the next presentation. But a question. There have been several questions, so you can address some of those as you finish. But can you describe the approach that you use for this for that surgery? Is it a midline exposure with undermining out to the to get to the crest, or what is your approach?
Yeah. So in the patient with a plan for a sacral decompression, I think you have to go through a midline approach, at least through the distal segment. So we do a midline approach and mobilize the erector spinae muscle out to the base of the posterior superior iliac spine. And just below that is the insertion of your iliac bolt. If you're doing a unilateral sacral fracture or bilateral sacral fractures and a higher injury, you may choose to do a posterior approach to the pelvic ring and extend that up into a Wiltse approach to give you access to the pedicles.
Great, thank you, Mike.